Sir, good afternoon, everyone. I will be talking about OCT in vitro interface disorders. So, I will briefly talk about the anatomy, the normal aging, and the disease pattern. There are namely 4 disease patterns in the vitreoretinal interface. That is vitreomacular adhesion, vitreomacular traction, a macular hole, and epiretinal membrane. So in anatomy, vitreous makes up 80% of the total eye volume, mainly water, 90%, 2% protein, and other constituents are there like hyaluronin, chondroitin sulfate, fibrillin, and opticin. The main point of attachment of vitreous is strongest at optic nerve, macula, ora serrata, and around the blood vessels. So this is normal vitreoretinal interface. In this picture, you can see the vitreous is attached. The fovea is normal in contour. So normally with aging, there is 2 processes, synchiasis and syneresis. There is liquefaction of the vitreous and there is vitreous condensation. So there is separation, which we call posterior vitreous detachment. The problem happens when there is mismatch between the liquefaction and the separation. So this is normal posterior vitreous detachment. This is the clinical picture. We can see the V's ring, and in the OCT we can see the posterior cortical vitreous is totally separated from the disc as well as from the macula. So when does the disease happen? It happens when there is anomalous separation of vitreous cortex from the hilum, which lead to the abnormal vitreoretinal interface. It also occurs if the liquefaction process is happening faster than it is separating. So there are 4 interface disorders. First is the vitreomacular adhesion. This is basically a part of normal posterior vitreous detachment. In this, the vitreous is attached at the fovea and it is separated in the perifoveal area with the normal foveal contour. So this is physiological change. There's nothing is to be done for these patients. This is just to be observed. According to the International Vitreomacular Traction Study, they are characterized into 2 types based on the size. The focal, which is less than 1 disc diameter, that is less than 1500 micron in size, and the broad one, which are more than 1 disc diameter, that is 1500 micron in size. There are 2 types of VMA. They are asymptomatic, non-pathological, considered as incomplete PVD, but they can resolutely progress to the vitreomacular traction or macular hole formation. The second entity is vitreomacular traction. In this on-slit examination, you will not find anything obvious. There are subtle changes unless there is very huge traction and there are cystic changes or there is subretinal fluid. So normally you can miss these cases on slit lamp examination. But if the patient is complaining of decreased vision or metamorphosia or for prior to the cataract surgery, so it is you can miss this kind of cases. So this is a case of vitreomacular traction. They are again divided into focal and broad, depending on the size. So these are usually associated with macular thickening, vascular leakage. If you do the angiography, they will leak, and they can lead to macular stasis and CMO. 1/3 of these cases resolve spontaneously, but if the patient is symptomatic and there is progressive decrease of vision and there is metamorphosia, then we need to resort to the surgery. So mild cases can be observed, and if there is progression, there is metamorphosia. In that case, the vitrectomy needs to be done. In this case, during vitrectomy, the important thing is we need to remove the anterior posterior traction as well as the tangential traction. And we should not pull it from the fovea, otherwise we can convert it to the full thickness macular hole. So usually surgeons leave the attached part and remove all other posterior cortical vitreous. In outcomes, visual acuity improvement is seen in 44 to 78% of the cases. In 1/3 cases, there is 2-line improvement. Sometimes visual acuity may not improve, but metamorphosia will improve. And there are cases in literature where doctors have operated on 6/6 vision with metamorphosia, and there is improvement in the metamorphosia. But this is a rare thing, not done routinely. And complication, as we see with the vitrectomy, bleeding, RD, cataract development, intraoperational tear, and post-op RD formation. There was ochriplasmin was once used, but it was not that successful. There are certain disadvantages with that. It was expensive. overall success rate was very poor, and people had compared it with the normal saline, and they have seen the similar rate of separation. And the most logical explanation was it is because of the mechanical separation due to the injection rather than the ocriplasmin itself, and it was there was complication also with the ocriplasmin, pharmacological complications. Now the third is full thickness macular hole. We all know the incidence is 0.05%. Very common in the female predominance is there. The clinically, initially they were divided by gas into stage 1A, 1B, stage 2, 3. But now, according to the IVTS, we are not staging it at 1, 2, 3. According to it, now we are describing just on the basis of the size. So it is small, medium, and large. And the size is at the smallest size. We have to measure it the smallest area. In surgery, for the stage 1 halls, stage 1 resolve, 50% of the cases will spontaneously close, and 50 will progress to the advanced stages. In stage 2, 75% will progress to 3 and 4, and in 3 to 22% of the cases, they are bilateral. Usually, the macular hole surgery, the results are quite good. And in 5% of the cases, we get 20/50 or better vision. In 55, it's 20/100 or better. So management, if we do vitrectomy with gas tamponade, for small holes, we can use the SF6. But if it is a large hole, we can use the inverted ILM flap along with the long-acting C3F8 gas. According to the studies, if we combine it with phaco, the success rate is higher. Face down positioning is conventionally for 2 weeks, but nowadays 3 to 4 days is sufficient according to the recent studies. And ILM peeling is usually required in all the cases. And closure rate is 91 to 98%, and median post-op seen is 20/40. Then there is lamellar hole. Lamellar hole is basically there is partial defect with the intact photoreceptor. These patients usually have very good vision, and we usually don't operate such patients unless there is progressive. People are operating such patients. We are usually not operating because they usually have 6/6 or 6/9 vision, and it is because of the anomalous PVD or abortive full thickness macular hole formation. The last entity is epiretinal membrane. It is cellular proliferation that create a semi-translucent fibrocellular proliferation on the surface. The glial cell migrate through the interruption in the ILM after PVD. Patient will complain of blurring of vision, metamorphosia, micropsia, or even monocular diplopia. On clinical examination, you will see on slit lamp, on biomicroscopy, you will see the reflective sheen over retina or wrinkling on the retinal surface. So this is the OCT picture if you take the OCT. As far as classification is concerned, there are different, people have given different classification. This was given by the Korean group. They have divided ERM into 2 groups. One is fovea attached type. Basically in fovea, the ERM is crossing the fovea, whole of the fovea, and this is pseudo-hole type. In this, the fovea is not covered. So when fovea is not covered, that is group 2. They divided group 2, 2A and 2B. 2A is pseudo-hole type. There is vertical steepening of the walls, and the 2B is schisis type. There is splitting in the layers. And fovea attached type, first one is, there is normally elevation of the foveal dip. In the second, there is ectopic foveal layer. So in this, you can see there is no ectopic fovea. In this, you can see the layers are there in the fovea. And the third one, which has the worst prognosis, is the group C. So by looking at the OCT, you can give the prognosis to the patient, and you can decide whether how much vision will the patient will gain. Those group C, 1C will have the worst visual prognosis. So these patients are usually, if there is mild, the vision is better than 6/18, so we will not operate, we will just observe, because 87% of them remain stable over 2 to 4 years of follow-up. Only 15% of will have poor vision and are the candidate for surgery. So surgical indication is either there is progressive deterioration of vision or there is significant metamorphosia. So in this, we do pars plana vitrectomy with peeling. We usually do it with the double staining and peel along with the ILM until the arcade to ensure the complete removal. that help us to have less recurrence and better final visual acuity. So in conclusion, the study highlighted that the eye undergoing cataract surgery, which is important for everyone, regarded as normal by retina surgeons, showed such type of deformity on OCTs. There's more than 20% showed subtle change in OCT that were not detected clinically. So it is very important, even if the retina seems okay, you should do OCT prior to the cataract surgery. It's an important instrument in armamentarium of an ophthalmic surgeon. Pre-op OCT should be considered. It can help in the progresses of post-cataract surgery. Thank you.